All right. It is just at the top of the hour. We're going to go ahead and begin the webinar. Welcome, everyone currently on the webinar, and to those that are going to be tuning in remotely, welcome onto the webinar. This is an SCCT webinar. Today's date is May 7th, 2026, and I am absolutely privileged to be joined by Dr. Stephan Achenbach, who really requires no introduction, to provide his insight into the past, present, and future of cardiac CT. Dr. Achenbach, before I bring you in, I want to sing a couple of your praises and make sure that the audience is aware of the enormous contribution you have to the field. As many of y'all know, Dr. Achenbach is widely known as one of the principal architects of modern cardiac CT. He's a professor of medicine and chairman of cardiology at the University of Erlangen in Germany, where over 3 decades of time he's contributed enormous amounts to the research of coronary atherosclerosis, coronary CT angiography, and the integration of imaging into structural cardiology. He was really instrumental in transitioning cardiac CT and coronary CTA in particular from its experimental phase into what is now recognized as a foundational diagnostic tool in cardiovascular pathobiology. Dr. Achenbach was a founding member of the SCCT and served as its first president from 2005 to 2007. Beyond that, his influence in the SCCT ranges from being a former editor-in-chief of the JCCT, and as we know at the ASM, he has his perennial role as the host of the beloved CT Jeopardy forum. His legacy is obviously further cemented by the SCCT Stephan Achenbach Pioneer Award established in 2019. This award continues to honor those who emulate his dedication and his passion towards innovation and education in cardiovascular imaging. I promise, Stefan, I'm towards the end of my tooting your praises, but a little bit beyond the SCCT as well. You were the recent past president of the ESC from 2020 to 2022, bridging that very challenging time period in medicine, global medicine, with the COVID pandemic. Beyond that, you've played a pivotal role in a multitude of cardiovascular medicine and imaging guidelines, including the recent CADREDS 2.0 guidelines. Stefan, welcome to the webinar, and we are so excited to have you here and so thankful to have your contribution to this field.
Thank you for the invitation. It's my pleasure to be here, and I hope I'll have something interesting to say.
You have had many interesting things to say over the decades of your career thus far, and that's kind of where I want to begin, is at the beginning, at the genesis. There are a few clinically practicing cardiologists and imagers that not only have they seen, but were foundational in the creation of cardiac CT as a important tool in the diagnosis of coronary atherosclerosis. I was wondering if you could look back to some of that foundational work in establishing cardiac CT and talk about what the easy parts were and what the hard parts were. What were the biggest hurdles that you had to overcome in getting it recognized by the community?
Well, there are two steps probably that need to be talked about. There were a few very early enthusiasts who recognized in the early 1990s that the electron beam tomography scanner, which was back then used to detect coronary calcium, might have actually a role to visualize the coronary arteries themselves and to identify stenosis. And there were lots of technical challenges to overcome on how to actually do this, how to acquire the images and how to interpret the images and actually look at the images, because such a thing as a workstation was not around in the 1990s. So in fact, the first scans that we acquired, we would print out 40 cross-sectional images of the heart on plain X-ray film, and then you looked at the plain X-ray film against trying to trace the coronary artery from the one slice to the next slice. Those were the very, very early scans in the early 1990s. And then there were so many aspects which had to be addressed. When is the best time point in the cardiac cycle to acquire the images? It's actually when the heart rate is higher. It's better to be in systole than in diastole. I remembered when we simply had the idea to simply try this because we had this problem with motion artifact. So there was a lot of creativity back then and finding solutions for problems, and the excitement of, with a few others who did the same thing at the same time, of showing that this is actually possible. So that was the first step. And the advantage back then, of course, was that regulatory requirements were a lot less. And with a few patients, you could show that something is possible and you wouldn't have to to do a study that has 3,000 or 4,000 patients, because in the initial stages, there are different questions. So that was the first step to show that this can actually be done. And then all the technology started to develop, moving from EBT to multi-slice CT with increasing numbers of detector rows. And the next big step then was, when the large trials showed that patients in whom this is used for diagnostic purposes do equally well or even better than patients who are worked up with other methodologies. And I personally think that the individuals who ran these trials, the Prospect trial, the Protect study, the Scott Hart, and recently the Discharge, I mean, they are the ones who really moved the field forward. Also, the Confirm registry, which showed what it means on a very, very large scale if you have a clinical CT scan, what it means for your future and the event rates. Those were the really, really important studies, which happened in the 2010, 2015 time frame. And then we got this into the guidelines, first timidly and slowly, which is good. And then as of 2024, 2025, now, of course, class one recommendation preferred over other modes of testing. Now it's really taking off. Yeah. So two steps. First, getting the technology started, showing that this is actually possible. And then the second step of these admirable studies which show that there's a clinical value.
Awesome, Stefan. I love that. The technology to the evidence to the guidelines. It's a beautiful flow of not only what our conversation is likely going to be, but also your contribution to the field. You had mentioned the transition from electron beam into multi-detector CT. Could you speak a little bit more to those that did not work with the Imatron or other electron beam CTs as to what the easy and the hard parts were with that transition?
Well, the electron beam tomography scanner, most of those listening to this, to the two of us talking, will probably not even have been born at the time. The late 80s and early 90s, there were, I think it was about 100 electron beam tomography scanners which were manufactured and were in service around the world by a company called Imatron in San Francisco. The initial idea was to study cardiac perfusion with this machine, because this was when nuclear medicine started to show that there's a value in perfusion imaging. So somebody thought, well, we can use CT to do this. And if you want to image the heart, we have to be really fast. That was Douglas Boyd, one of the early engineers who founded the company in Princeton. We have to be really fast. So he constructed this massive machine which had no rotating X-ray tube. Basically, the patient was lying in a large X-ray tube, and there was only an electronic deflection of the electron beam to generate the photons that would penetrate the body. So no mechanical movement except the table moving up incrementally stepwise. And we could acquire 3 mm slices, thick slices with reasonable noise, and 1.5 mm slices with terrible noise. And the acquisition would take about 45 seconds. So the patients would have to hold their breath for 45 seconds. And so we would actually inject atropine to speed up the heart rate. Our target heart rate was 90 beats per minute, so that the data acquisition could be finished in a reasonable time, because the machine could only acquire a slice at a time, or with a lower resolution, 4 slices at a time. It was really a challenge to get these data in. And then the very low spatial resolution. And then the problem was that calculations were done. But it was pretty certain pretty soon after we showed that the coronary arteries can be imaged by this, that higher resolution is necessary, thinner slices than 3 mm. And in order to achieve sufficiently low image noise, a lot of more photons would be needed. And the mathematical and physical calculations showed that the electron beam would have to be so strong that the metal would melt. It would become so hot, the cooling is simply impossible. So this was the end of this technology. It was simply shown by the assumptions, what is necessary to have thinner slices at reasonable noise, that this cannot be done with this technology. The tungsten is the material of which these targets were made, it would melt. And this is what prompted several companies to invest in making the conventional CT technology faster and faster and faster. And and this happened around the 2000s, that the 4 slice and then 16 slice CT came about. And 4 slice and 16 slice was still extremely challenging to image the patients. The 4 slice image quality was about the same as EBT, but of course, 4 slice CT scanners were much more widely available. Acquisition would also take about 30 seconds, and the temporal resolution was 400 milliseconds or something like this. But then the slice numbers became more and the scanners became faster. And as of 64 slice CT, that was the big step. With the 16 slice CT, it still took a lot of coaching with the patients and very, very, intensive work with the patients and the data acquisition to get a reasonable data set. And then when 64 slice CT came about, suddenly the data acquisition was only about 8 to 10 seconds, and heart rate didn't have to be as strictly controlled because the scanners were a bit faster. 64 slice CTs changed everything because this is when it started becoming a routinely usable test for many patients. I wouldn't say for all patients, I wouldn't even say for most patients, but back then, at least for many patients with suspected coronary artery, the 64 slice was the big change.
Stefan, was there a specific moment or set of moments where it was an aha or a eureka moment where you recognize that this technology in its infancy is going to become what it is today, this titanic diagnostic force? Was it was it a specific memory that you have, or was it a gradual build?
I very much remember the very early times. I was, I think it's a resident here. It was my first year of actually working as a doctor after finishing medical school. And we did these CT scans with the electron beam tomography scanner, first calcium. And then we suddenly had the idea. And that's the thing, you have to be creative. You have to have ideas, right? And we suddenly had this idea, why don't we inject contrast and see whether we can see the lumen? Why not? Let's just, do this. And we did some preparations. And initially, we would put pigtail catheters into the aorta because we thought it would be really good to inject the contrast agent right into the aortic root. Didn't work very well because there was too much unenhanced blood also entering the coronary arteries. So intravenous was much better. And we were cardiologists. We didn't have experience with how to time the contrast injection and the acquisition. We had to find this all out. But then I remember very well how we, as I said initially, we printed out these cross-sectional images, and it was very hard to trace the coronary arteries, yet alone to determine whether there was a lesion, a stenosis. But then somebody came about and said, we have this machine and you can do 3D reconstructions. You have to enter the data, and then it runs for a few hours, and then you get a 3D reconstruction, and you had to program the angle out of which you want to see this 3D and all of this. We would often do this in the evening and come back in the next morning to get the 3D reconstruction. And I remember the first 3D reconstruction that we saw. I still remember the patient's name, where we thought, oh, there must be a lesion in the LAD. There's this interruption of the LAD on this 3D reconstruction. And the next day she had the cath, and she actually had exactly this stenosis. And this was an unbelievable moment. And we thought, maybe this is really possible. Maybe this is really possible. But we wouldn't have thought how long it would actually take to become clinically applicable, because if you think about it, this was in 1993, early 1993. And until we had this in the guidelines was around 2019, the first class one indication in the ESC guidelines for 2019. So that's almost 30 years that it took. It's amazing, an amazingly long time. A third of a
Stefan, you
century. Yeah.
Stefan, you had mentioned a few of the foundational, the pivotal trials in the, we'll call it the earlier time period of demonstrating the evidence base in the early 2000s. But why did it take so long, right? The proof of concept was present in the early to mid 90s, but only in the late 2010s, I would argue, do multiple multinational societies now accept this as a diagnostic tool for the assessment of patients who have symptoms, right? Chest pain equivalents. Why do you hypothesize it took that long, whereas other technologies may not necessarily have taken as long to be implemented into evidence-based guidelines?
Yeah, I think it's a technology thing because, as I
Hmm.
said earlier, acquiring a cardiac CT data set with electron beam tomography, certainly, and with 4 slice, 12 slice, 16 slice CT was an adventure. And it was only done by a few enthusiasts. And it was really only when 64 slice CT became available that there was the possibility to scan more patients at more sites. So this technology had to be developed first. And I don't remember exactly when the 64 slice scanners came out. It must have been around 2004 or so. And then, give it about 2 or 3 years until there are enough of those scanners installed and people know how to use them. So suddenly it's 2010 and you can start thinking about trials. And this is how things go. Then the trials, they need a follow-up, right? So, I mean, the trials, Pam Douglas, Udo Hoffman, and the trials that they designed, they really changed everything, showing that this can be done in a group of 10,000 patients, in many, many institutions, not just a few enthusiasts and very, very early adopters. and that this actually provides diagnostic information, which is similar to what was usually done nuclear medicine studies. That was the real what really moved the field forward.
Excellent. I want to start transitioning from our conversation about the past to things that are presently applicable in diagnostic coronary imaging. Uh, but hearkening back to those earliest moments of the eureka, that prox-LAD stenosis that you had mentioned, was there an understanding of the translation of our current understanding of atherosclerotic plaque morphology back then too, or was it more a binary approach? Were we looking simply at stenosis severity?
Nobody was thinking about plaque back then.
Hmm.
It was all about finding stenosis in patients who have symptoms to see whether they need an invasive angiogram to fix the stenosis so that their symptoms would go away. And everybody assumed back then that if you remove a stenosis that causes symptoms, you also improve the prognosis of the patient. And it took the cardiology field a long time that that's not necessarily the case. And the pendulum swings sometimes too far on the one side and too far on the other side. If you do remove a 99% LAD stenosis, which causes symptoms, i.e., ischemia, I'm sure it also has prognostic value, while for many other stenosis, that's not the case. And that's actually what troubles us until today. We can speak about this a little bit later. But in the early time, it was really only finding stenosis. And it was only when the 16 slide scanners came about. And I remember how we had very early trials that looked at the actual detectability of plaque in comparison to IVUS, intravascular ultrasound. And just out of curiosity, this was the exploration phase, when we were still playing around with what does the kernel that we use do to the diameter of the coronary artery that is reconstructed, and how much noise is acceptable, and suddenly also, can we detect plaque and can we see plaque that is in IVUS? We defined plaque back then as structures that are more than 1 millimeter in size and do not belong to the coronary artery lumen or to the myocardium, so they have to be plaque. It was very crude. That was because 16 slide CT for the first time had the image quality to actually do this. And the reference studies were available, IVUS, but it was only back then also, as you say, yes, no, per segment, we would look at whether there's plaque present, yes or no. And only when the image quality got better, we could think about plaque quantification, but it was far away from what can be done today. Sensitivity to identify plaque and also the abilities to quantify plaque. But I'm sure we're going to talk about this because just the many possibilities that we have today doesn't say that it's gotten a lot easier. If you're too sensitive, you can also have problems, but I'm sure we'll speak about this a bit later.
Yeah, let's start bringing that into the discussion now. So you've been integral to the creation of a standardized lexicon for reporting coronary CT angiography, not only the initial CAD-RAS, but now the more recent CAD-RAS 2.0 lexicon. As part of that, many of the webinar listeners probably are aware that there's been more and more integration of descriptions of plaque beyond just stenosis severity. In fact, there's almost two concurrent paths of describing coronary lesions in these lexicon. Can you talk about how these have slowly been integrated into our interpretation of coronary imaging and reporting of these imaging?
I will be very, yeah, maybe disruptive here if I say that the CAD-RADS, we all know it's imperfect. We're
Hmm.
troubling ourselves at the moment very much with describing, that's my interpretation, describing coronary atherosclerosis and the two consequences that it can have. A, causing symptoms, and B, impacting the patient's prognosis. And completely independent of CT, we never really know whether a lesion that is maybe not 99% causes the patient's symptoms. We never really know whether the lesion is 80% or 60%. It could, it might not. We don't know. Even in the revascularization studies, 30% still have angina afterwards. We never really know whether a lesion causes symptoms, and we never really know whether a lesion will cause an event later on, yes or no, whether it's 40%, 50%, lots of plaque, or just a little plaque. It's a very big area of gray. And we don't know whether the stenosis degree, the amount of plaque, or the type of plaque is the most decisive factor. And we tend to forget the location of plaque also. And the CAD-RADS is an attempt to use what CT can deliver or could deliver at the time to move us a bit forward in describing the plaque. But if we see the current happenings, I'm always almost expecting that CAD-RADS will be replaced by reporting the volume and the burden of plaque. And then we have to see which other plaque components remain predictive beyond. plaque burden and plaque volume and stenosis degree. At the moment, it seems that stenosis, maximum stenosis degree, and the amount of plaque are the two most important factors, also with the amount of low density plaque. But this, this descript, yes, vulnerability, yes, no, or stenosis degree so much, and let's forget the rest. I think the cataracts is probably just an intermediary step, and we are going to move towards something that is very continuous in scale, but I'm very, very difficult to predict what it will be.
Without getting too far into the weeds here, Stefan, we're talking about concepts of anatomy, stenosis, and concepts of morphology, the plaque. Any thoughts about the recent introduction of non-invasive physiology in interpretation of coronary CT imaging?
Yeah, that is amazing, what these simulations can do. But as I'm very, very actively involved in treating patients who have coronary artery disease. I have big doubts that physiology will give us all the answers that we need. I see too many patients with FFR values, whether they're measured invasively or non-invasively, who are above the 0.80 magic, threshold, and they do have symptoms, and then somebody decides to remove the lesion and the symptoms goes away. And I see patients who have lesions where in the cath lab we measure the FFR is 0.86, and we say this doesn't have to be revascularized. It's neither prognostically nor symptomatically relevant. And then 2 years later, the patient comes back and has an acute coronary syndrome at exactly this location. So this binary nature of these physiology measurements, I have never been fully trusting them, and I'm probably not embracing them as much as I should, both invasively. I have my doubts about this, and non-invasively, which does not mean that I'm criticizing the attempt to do it, because we want to predict much more and much better than we currently can what the relevance of a lesion is. And we would like to find something, but the holy grail hasn't been found yet. And it's probably not just a single parameter. It's simply very, very difficult to predict which lesion causes angina and which lesion will cause an event. It's very difficult then. And the solution has not been found, will probably never be found, because it's just so multifactorial that there's not going to be the one single parameter that helps us.
Yeah, I think that last point about the fact that this is likely a multi-parametric approach probably resonates with many of those in the audience, and that there are so many pieces of data that we can get from this tool. Yet, discussing some of those guidelines both in Europe and the United States that we were mentioning earlier, where we've now elevated coronary CT angiography as a totality, as a tool, to a class 1 recommendation for assessing our symptomatic patients. Yes, we can extract a tremendous amount of data from coronary CT angiography, but in totality, it seems to be accepted by a lot of the communities across the world. What then do you envision are some of the challenges of getting coronary CT angiography to the communities that don't currently have mature, robust programs?
Well, these are many questions at the same time. The question that you asked last is, how do we get this so that more patients can benefit from what CT has to offer? And unfortunately, of course, it's going to take a long time, but we will see a democratization of access to very high resolution CT systems, because simply as the next generation is developed, the current generation will become cheaper and more widely available, as we have seen with previous generations. And if it's good enough today to scan the patient with these machines, it will be also good enough 10 years from now to scan patients with these machines. And we shouldn't always think that it's only the latest technology which is adequate, so that only a few centers can do adequate work. So, of course, I mean, medicine is never going to be completely fair, unfortunately, but I'm convinced that more and more patients will have access to this, because there will be more machines out there and the programs that are running will be upscaled so they can accommodate more patients. At the moment, I have the feeling that it is very problematic to take care of patients with chest pain, patients with coronary artery disease, and to determine their care. How intensive should they be, if they have no obstructive lesions, how just risk factors, how intensive should the risk factor modification should be? If they have symptoms, should they be revascularized, yes or no? Should they be sent for an? It's difficult. And at the moment, I feel that the cardiology community is, at the one hand, reasonably using CT in patients where it's reasonable, but it's also an easy way out sometimes. If you have a patient, you don't really know what to do with him or her, and you say, yeah, let's do a CT scan. I'm sure the CT will give the answer. But the CT gives a very clear answer if it's completely normal or if it shows very severe stenosis. And in the gray area in between, it doesn't provide the guidance that is desirable always, right? There's often still reason to debate what to do with these individual patients.
I want to ask two subsequent questions from that response, and I'm going to touch on a couple of audience questions that are related to this too. For those in the audience, please feel free to use the Q&A function to drop in questions. I'll intermittently bring them into our conversation, and we'll have some time at the end to talk about specific questions that I didn't address in the convo too. But regarding your response, Stefan, we want to optimize our ability as imagers to provide the best information possible to make management decisions for the patient. In a pragmatic way, what do you recommend or currently use for post-processing tools to interpret coronary imaging? Are something as straightforward as multiplanary formats or something as sophisticated as advanced quantitative plaque analysis? What are you currently using, or would you suggest that our imagers use?
Yeah, well, we use multiplanetary formatting for our readings. We use, of course, quantification of the calcium score, but we do not at the moment quantify plaque volumes because we don't at the moment have a good feeling for how reliable each individual software is and how to compare one software product with the other one. Even though I'm absolutely convinced that there will be a unification of this, we will get very standard readouts by different software programs, and 3 or 4 years from now, everybody will be using this and report plaque volumes. It would be absolutely necessary that we all do this. But at the moment, I
And
mean, in a normal scan, you're very fast. A scan that has no plaque at all, you're very fast to just with the very basic tools to read the coronary arteries and determine that they're normal. You have to be a bit careful with the automatic quantification that is available. Sometimes they're oversensitive. There's one famous trial which found plaque in 99% of patients. So it shows that standardization of these tools needs to be done.
excellent. And to complete the response to our audience question here, of the tools that you had mentioned in terms of the traditional approach to interpreting coronary imaging, do you tend to gravitate towards interpretation off of the orthogonal reformats, off of multiplanar reformats along the curve of the coronary tree, the so-called CPRs? Do you utilize three-dimensional volumetric analysis?
Yeah, 3D, not at all. Excellent orthogonal slices in most cases, and occasionally, because it comes for free and is sometimes very easy to look at, the curved multiplanar reconstructions. But the curved multiplanars, they can sometimes underestimate if the stenosis is very eccentric and you happen to have a view and not look at all of the directions that doesn't show the lesion. There is a very interesting tendency that I observe because I assume that there will be many photon counting users out there, um, uh, um, that it has become different to read with the photon counting CT. With the somewhat lower resolution of 64 slice CT, dual source CT, 320 slice CT, whatever the generations were before the photon counting CT, the resolution was slightly lower. There was always a tendency that CT images would overestimate stenosis degree because maybe the signal dropout in a very narrow lesion of the coronary arteries would be such that the lumen would almost disappear in a high-grade stenosis. Now, with the photon counting CT, which has higher resolution, and it will also be the case for other scanners which somehow get higher resolution, we don't see this dropout anymore. So we really had to retrain ourselves a few years back when photon counting CT came around, that we don't start to underestimate stenosis because we still see a lumen, even though they are really severe stenosis. So you have to train your eye to the scanner that you're using. It's very important to get feedback, right? Any feedback that you can from a scan that you have seen and the patient goes to the cath lab because a cath was recommended. And we still do it. We have seen thousands and thousands of comparisons because we often actually do the examinations, and yet we always still meet every week and look at scans together, which had a CT scan and an invasive angiogram. So we continuously train our eyes. It's very important to get this feedback. Very, very important.
So this brings me to another audience question in that many of us, including yourself, are multi-modality imagers. You're looking at CT, at catheter angiography, at echocardiography, and other modalities. Um, you mentioned some of the limits, if you will, of traditional non-spectral or non-photon counting CT techniques. With the advent of photon counting CT, does this change how we utilize multimodality approaches to coronary atherosclerosis? Is it changing need for certain types of, say, invasive angiographic techniques? And don't mean to add in an additional question in there too, but are you utilizing functional imaging or cine imaging, if you will, from CT as a surrogate for or complementary to MRI, echocardiography, et cetera, in assessment of patients with any cardiovascular diseases?
No, we're not currently using cine scans except in very, very exceptional circumstances. And the one that always comes to mind is the patient who has a left ventricular assist device and there's no echo image window and MR is impossible. And you want to see whether LV function has improved. And that's, the poster child for using CT for functional assessment. Other than that, we don't, because usually echo and MR will do the job and the radiation exposure needs to be taken into account. So we don't do this. We do scan, of course, sometimes multiple phases to improve the image quality when the heart rate is maybe not perfect, but never the entire cardiac cycle for radiation protection reasons. And then you asked whether the photon counting CT replaces other image modalities. Yes, certainly. I think we can rule out um, significant coronary artery stenosis, whatever this is, that require downstream invasive testing in many more patients now with the photon counting because the image quality is more reliable than with the 64 slice 120, 128, 320, whatever the previous generation's dual source. So yes, more invasive angiograms can be replaced. On the other hand, we do more CTs, a lot more than before. So we also send, of course, patients to the cath lab, maybe more than before, because we see more higher risk patients now in the CT than we used to.
Excellent. Now that we're talking about concepts like photon counting CT and other, we'll call them cutting edge technologies, I think it's a natural transition from what we're currently practicing to what you expect to be practiced in the future. Um, the majority of our discussion has been about symptomatic patients, about patients with chest pain equivalents. And I'm curious to get your take, Stefan, on if there is a role, either evidence-based or not, for cardiac imaging or cardiac CT in particular in our asymptomatic population as more of a screening tool than a diagnostic tool.
The data doesn't show it because it's difficult to capture the individual situation. Um, there's no data that would show that at the moment, screening asymptomatic individuals with the CT angiography will reduce downstream events. There are trials on the way, such as Scott Hartoon, and we're all waiting for those. But for the truly asymptomatic population, screening by coronary CTA, reducing events has not been shown. But I feel that, of course, in medicine, there's always individual considerations. And we all know patients where maybe, and the typical example once again is the person who's 50-year-old and shows up and says, my brother had a myocardial infarction when he was 52 and he's dead now, or he had bypass surgery. I don't want to have this to happen to me. Can you please do a CT angiography? My LDL cholesterol is not perfect, but it's not terrible. And I want to know what's going on in my coronary arteries. And then you find the proximal LED stenosis. All of us who do cardiac CT have identified these patients who then need really, really intensive management, even though it's not completely clear who needs to go to the cath lab. But these individual circumstances, I think, need to be considered, and we have to be a bit more generous, right, than we should be. The guidelines say no CTA in asymptomatics, but I think there are situations, for example, strong family history, where the diagnostic information is useful. And but a general screening at the moment, open it up too wide, I'm a bit reluctant. Because then there are so many individuals who will be found to have plaque, atherosclerosis, and we don't really, really know what is the threshold at which this individual will benefit from treatment. I mean, this is really the most important question. At what threshold, at what amount of plaque is a treatment necessary and useful? How does age impact this? Because you can say, yeah, very little plaque in a young person is not that bad because it's only a little plaque, but then this person has many, many years to develop more severe atherosclerosis out of this. In an old patient, maybe a 38 cubic millimeters of plaque shows that this person has a very, very low risk, while in a younger patient, 38 cubic millimeters of plaque show that this person probably has a very, very high risk. It's really, really difficult. We have to figure out many things, age and gender and family history, other risk factors. What do they mean? If you have severe risk factors but only a tiny little plaque, or if you have quite a bit of plaque but no risk factors, we don't know the answers to these questions, and I'm sure we will get them in the next 5 to 10 years. But at the moment, it's very hard to make decisions on an individual basis that are really founded on evidence. So this is why I'm reluctant to opening this up too widely for asymptomatics. But I fully endorse that an individual patient needs an individual solution, and there are quite a few who come to see us, and they have severe circumstances and risk factors. We scan them and we find significant narrowings, and we assume that invasive angiography and potentially PCI to these lesions is beneficial.
Stefan, we started the technology portion of our discussion mentioning electron beam CT, and now we're describing the advances in photon counting CT with more and more vendors releasing clinically available tools. However, no one, to my knowledge, is currently using electron beam CT for the analysis of coronary pathobiology. Electron beam CT was critical in establishing coronary calcium scoring as a valuable tool in risk assessment. But now, our conversation here, we're talking about the volumetric assessment of low attenuation plaque or lipid-rich plaque. Just as electron beam CT has unfortunately gone to the wayside in assessment of coronary imaging, do we feel as though calcium scoring will go to the wayside, or will it always have a place in risk stratification?
Well, my estimate would be that a calcium score without the assessment of non-calcified plaque will just go away because the contrast is really not that much of a problem, and the additional information that we can get, I would assume to be relevant. It has not, again, been shown and explored exactly, but we know that there are some patients who have completely calcified plaques, which are not very large and probably have a relatively low risk, while some have, in addition to these calcified amounts, tremendous amounts of non-calcified plaque, and we need to know this, would be my assumption. It has not been shown, but my prediction, nevertheless, without evidence, just based on my estimate, is that the pure coronary calcium scan, even though it has very strong data at the moment, will be shown to be less informative than the addition of contrast and showing for non-calcified plaque, so it will probably go away.
Excellent. Stefan, are there any other technologies, either within or beyond photon counting CT, that you are anticipating will change the field of diagnosing and potentially determining the management of coronary atherosclerosis?
Absolutely. We are all very much focused on CT at the moment, but we're not looking at MR. And I've seen rather impressive MR angiograms. And we are 30 years away now from starting CT, and who knows how good MR will be 30 years from now. And if you look at echocardiography, you can also see tremendous advantages. I still sort of don't believe that echo will ever be able to visualize the coronary arteries, but I can be terribly wrong. There might be very enough smart people who said 30 years ago that CT will never make it, and it did. I think CT will always have a cutting edge because CT will not stay stationary. It will also improve. But I would be surprised if, a few decades from now, MR would still have a hard time visualizing the coronaries. I would expect that this is possible. And then if that's the stenosis detection part. Then for risk assessment, it is so multifactorial. Who knows what will come next? Which biomarkers will be discovered beyond just, lipids and it's very sensitive to troponin and things we can't even think of at the moment. And that will predict also the thrombotic part of the risk, the plaque rupture, the inflammation. There's still a lot that can be discovered. And who knows whether there will not be something that is more predictive. There's also a very important risk factor, which is symptoms, right? Symptoms. And again, there's a tremendous opportunity to reduce events. If everybody in the entire world would know that if you start to feel chest pain, you urgently have to see a cardiologist. And there's an opportunity, actually, I'm maybe fantasizing, but as people are using AI more and more in their everyday lives, if these algorithms would be programmed to detect changes in behavior, or who knows how intimate you will be with your personal AI product and how many of your thoughts you will share, on a day-to-day basis. And if you start complaining about shortness of breath or chest pain, this algorithm will immediately say, excuse me, if you have a chest pain, I'll make an arrangement that you see a cardiologist very soon. Maybe this is even more beneficial than lowering the lipids. Because 50% of patients who have an acute coronary syndrome have a bit of chest pain in the days before this. So there's lots of completely out there things that could also happen that make all of our lives better.
I love that. I love the future thinking about the various different parameters that are going to be put into place, and many of which may be completely automated in assessment of, well, the betterment of patients, but really things as interesting, as straightforward, but as technically complicated as chest pain as a symptom. Bringing back to what we're doing today in anticipation of the future, how do you approach cardiac CT today? How do you implement it into your clinical practice? Where do you find it most beneficial for your patients? Where do you find it least beneficial for your patients?
Yeah, clearly the workup of chest pain. I think it's a fantastic tool. Many individuals have chest pain. There was always the problem of doing stress tests here and there and still not really knowing what is going on. And the clarity of a CT scan that shows you whether there's something wrong in the coronary arteries or not is absolutely beautiful and game changing for many patients out there. I think this is still the quantitatively and qualitatively the most important use of CT. It can show the coronary arteries like no other image modality can. It can tremendously help to manage patients who have chest pain. I think it's underused in patients who come in with acute chest pain, at least in the sites that I see, in the countries that I see. We can probably use it more, but you have to clarify the logistics. Who is available at 8:30 a.m. on a Sunday morning to do a CT scan in a patient who comes in with sort of, murky chest pain, which could or could not be something, or the patient who came in who had a bit of atrial fibrillation and the troponin is slightly elevated. And why not, if you're back in a reasonable rhythm, do a CT scan and show that the coronary arteries are completely normal? I think in the acute setting, there's still a lot more that could be done, but this needs to be implemented. And then, of course, the entire area of structural heart disease interventions and the workup of structural heart disease. We all see how CT has, without anybody talking about it almost, with no specific studies to address this, has become super integral in the TAVI or TAVR, as you might say, field. We cannot imagine even doing a patient for transcatheter aortic valve procedures without having a CT scan that gives us all of this tremendous information. And for most of the new procedures that are being introduced, the new valves that are being placed, it's always a prerequisite to have a CT scan because it gives you this fantastic anatomy. So the entire field of structural, of course, is also something where we see CT becoming very important.
Stefan, I want to leave the last 15 minutes or so for some question and answer from our audience members. So audience members, please continue to submit questions into the Q&A chat box. Before we get to that, though, Stefan, I want to perhaps conclude this more didactic portion of our conversation with what you think this means for the education of cardiac CT, the past, present, and future. We described a variety of techniques that you have personally altered in the genesis of cardiac CT. We described the complexity of the current present of how cardiac CT is across. We focus primarily on coronary atherosclerosis, but in just the past few moments, we mentioned structural cardiology as a huge field in which CT is impacting the practice and the management of these patients. What does this mean for the future of education of this field, and what advice do you have for those that are going to enter cardiac imaging education programs?
Well, in all honesty, I think if it's reasonably done, the chances should be exactly the same, whether you are a cardiologist interested in cardiac imaging or a radiologist seriously interested in cardiac imaging. I think this field should be open to you. That is very important because it needs to be done by somebody who wants to do it. And it's not important whether this person who wants to do it and to thoroughly do it and to do it well and to consider the entire patient, not just the images, whether that person is a radiologist or a cardiologist, really, or a psychiatrist for all I care, as long as he or she knows what he and she is doing. But it has to be done with passion and a lot of experience. Two scans a week will not do the patients a very good service. It has to be a high volume enterprise, so to speak. That's important. So anybody who wants to do this, do as many scans, see as many scans as you can. And as I said earlier, it might sound, like a small thing, but if you interpret coronary CT angiograms and you never have a reference, you're just making up your own little fantasy world of what is a stenosis and what is not, and which patients should go to have further workup and which patients probably not, and where you say, I really can't say, maybe we need another non-invasive test before we do something else. The feedback with the invasive angiogram is invaluable. It's super important. So anybody who looks for a training opportunity should always try to find out whether in this place it is possible to see not only the CT being done, but if there's a downstream angiogram, if it's happening, to get a hold of this in a reasonable share of the patients, to train your eye and to train your interpretation over and over again. Because at the moment, the difficult part is still assessing stenosis severity. And that's where the comparison to a reference standard is highly useful and should always be sought.
Stefan, say we do have our trainee that is in a high volume program that allows for cross-referencing their calls, their interpretation on CT with another gold standard modality. How do we allay some of the fears of these trainees that their their interpretive role, their job as an imager may be no longer needed in the far future where non-human interpretation, artificial intelligence interpretation may come into play? Are those fears justified? If not, if so, how do you respond?
Well, sure. I would imagine so. I will, everything that is pure intellectual labor, and I mean labor, as it simply has to be done. The machines will help us a lot and take over a lot of the work. At the moment, it's still, every patient that I interpret and I don't see completely clean coronary arteries, I always ask immediately, is this patient symptomatic? What sort of chest pain does this patient have? Because it goes into the equation. And this is where probably some AI programs will be able to do the same, but the human factor of integrating everything that we know about the patient, from the patient's brother who had myocardial infarction and also only felt shortness of breath and no chest pain, everything that we know about the patient is so important. And this is important. But clearly, I mean, if you only read images, I think we all know that the only reading of images part is going to be taken over by AI. I'm lucky because I'm also wearing these and I do a lot of manual work. I'm not so sure that this will be taken over very soon, not before I go into my retirement by robots. But the pure interpretation part, I mean, I've been talking about it for 10 years and it hasn't happened yet. So it's probably still going to be a while. But we see it happening in the plaque quantification. It's completely clear that we will not manually quantify plaque, right? Completely clear. This will be done by AI algorithms. They need to be validated and compared to each other, and they need to provide the same results as other algorithms do. They have to be at the future before it becomes a product. They will have to show that they do this accurately. Now, this will be done by AI, and why not also, identify stenosis if you identify plaque? But then, what to do with this? This is where the human work probably will start. And then there's also the question that the AI will mark some areas as questionable and ask you to look at it because the AI program will say, "This is the mid circumflex. I'm not sure. Please make your own assessment." And then if you never saw the routine cases, you won't be able to help the AI algorithm a lot. So there is going to be a role remaining.
Excellent. Thanks, Stefan. That actually brings me quite nicely into the first audience question I want to bring in, which is about that far future scenario, but asking what you envision the role of cardiac CT in general, or perhaps coronary CTA in specific, will be not just in the next few years, but 10, maybe even 20 years from now. It's a more fun, speculative question.
Definitely, CT will, remain the go-to test for patients who feel chest pain or chest symptoms, and it needs to be determined whether there is a significant narrowing of the coronary arteries, which will benefit from revascularization, and whether there's atherosclerosis that mandates intensive risk modification. For these, patients, CT will remain the go-to test. In addition to this, and again, yes, of course, for structural heart disease, but in addition to this, the big question is whether CT will be able to establish that if used in asymptomatic individuals, maybe with some entry criteria, such as a certain age or a certain amount of other risk factors, that the use of CT will actually reduce events. And if that happens, it's very imaginable that maybe at some point, the insurance companies will say, as of 38 years of age, you have the right, and we ask you to please have your heart scanned once so that we know whether you need intensive risk modification, and you want to know, and we also want to know, because it's beneficial for your health and for our health expenditures if we do this. So if CT establishes this, and I'm pretty confident it will, that under certain circumstances, in these parameters, these entry criteria, doing a CT will reduce downstream events. At that point, things will change, and it will become what is currently the cholesterol test. You know. But we need this
Fascinating.
data first, and it's very hard for me to predict when we will have this. At least another 5 to 10 years, I would imagine, before we know the thresholds at which to initiate therapy.
I think that's part of the fun of questions like this is to see how you speculate it's going to be integrated into far future clinical applications. In fact, another audience question harkens to this. Um, do you think that at present or in the future, spectral CT analysis data of coronary arteries is helpful in either the diagnosis or management of patients? And if so, in the future, what do you envision coming from those spectral data?
Yeah, and there's two areas where we could potentially think. A, that spectral, analysis and workup of the imaging data that is acquired, the raw data, will help us improve the image quality and the assessment of lumen and plaque, just get better images and better information. And then, of course, there's the hope that spectral information will help us understand the composition of plaque better and make better predictions about risk. Everything is so murky. I don't think there's going to be the one parameter that says this is a high-risk individual and that person is below the threshold and nothing will happen to him or her. And this will never be the case because coronary artery disease, as far as symptoms and events go, is so multifactorial. But I would assume that spectral information will help us understand plaque better. We already see that low density plaque volume is one of the best prognostic parameters. If you look at the studies that are out there right now that used AI to determine plaque amounts and then follows the patients, most of these trials, all the ones that I know were not done in general populations. They were all done in patients who had a CT scan for a reason, so we have to take
Yeah.
it with a grain of salt. But basically, these AI studies of 6,000, 5,000, 3,500 patients in various countries and settings, they all show that total plaque burden, low density plaque burden, sorry, total plaque volume, low density plaque volume, and stenosis degree are predictive parameters for future events.
Excellent. Stefan, I want to now focus on a audience question that's a little bit more pragmatic and presently applicable. It's regarding a specific lesion type, a prox-LAD lesion that is greater than 50% in diameter narrowing. The question is regarding a potential discrepancy between what to do about this lesion between US-based and Europe-based guidelines or ESC-specific guidelines. The question then goes on to ask, is there any role for doing either invasive or non-invasive physiology on the CT imaging data for lesions that are of this particular type? And what do you do management-wise with these patients beyond, say, revascularization if needed? Or the question asks about statins, about aspirin. We can extend that even beyond that to PCSK9 inhibitors, SGLT2, etc.
Yeah, very generous with statins. When we see plaque that is non-negligible, we in our institutions are very generous with statins. And if there's a lesion that is 50% or more, that's even when the guidelines say that statins should be employed, usually with a threshold of LDL cholesterol less than 70. But that's when the guidelines say if you see lesions more than 50%, that's when you should think about statins. So the 50% threshold really helps. We also are generous with statins with lesser amounts of stenosis degree as long as there's non-negligible plaque in the coronary arteries. The aspirin recommendations are super restrictive. Aspirin in primary prevention, whether plaque or not, is problematic because it causes a tiny bit of bleeding. So me, my colleagues, and everybody I know are super restrictive about recommending aspirin. The revascularization question, 50% lesions usually are not hemodynamically relevant. And that's from all the studies that we do. it probably usually needs to be 70% and relatively long, or more severe and a bit shorter than also. But with a 50% lesion, revascularization, no. But the almost immediate question is, does the patient have symptoms? Does the patient have symptoms? Does the patient have symptoms? Because if the patient is already on lipid-lowering drugs and the stenosis is not super severe, more than 90% lesions have a very high risk of something happening to them, then probably he or she is protected already. And the question about revascularization is very much about symptoms, yes or no. So it's very hard to interpret a CT scan if you don't know whether the patient has symptoms and what type of symptoms.
Fantastic. And just question from me, for those of us that are interpreting CT data in somewhat of a vacuum where we don't necessarily have access to all of the information for the patient, either because the patient themselves have opacity in describing their symptoms, or the electronic medical record, the physical medical record is just not available. What do we do? What's the best
Well,
approach?
very easy solution to that. That's what we do. If we don't know about the patient's symptoms, we write it down. We say, if this patient have symptoms, then do this. If this patient does not have any symptoms, then do that. Right? I mean, that's what you can do. And also, unfortunately, I have used the analogy before. We are not orthopedic surgeons, right? You know whether a hip is broken or not. In coronary artery disease, it's a continuous spectrum of a bit of a lesion, narrowing now, more narrowing, very severe narrowing, completely continuous, a bit of plaque, more plaque, lots of plaque, and almost no plaque, and lots of plaque. And you never know what this means for the patient. We are always operating in a gray zone. So using CT, getting this additional information, it can probably help you make fewer mistakes, but it will never avoid that you do not justice to a patient, because even though there was a lot of plaque, the patient would have never had an event. Or a patient who has tiny amounts of plaque and has the very high, very unfortunate event, even though all probability was against it. We can never be absolutely sure with coronary artery disease. That's the problem. And the old epidemiological wisdom holds true in all of the trials that I've seen recently. The SCAPIS trial, which scanned 25,000 patients in Sweden from the general population, or the Copenhagen City Heart Study, which studied 10,000 asymptomatic individuals and did the CT and followed them for a while. And the old epidemiological wisdom is that yes, high risk individuals have a higher risk of events. But most events still occur in low risk individuals because there are so many more low risk individuals than high risk individuals. And you will never be able to eliminate all events by focusing on high risk individuals and treating them intensively, even though, of course, you need to do this because you don't want to avoid them from getting a myocardial infarction. The epidemiological wisdom is that most events occur in low risk patients because there are just so many low risk individuals out there.
Stefan, we're coming to the last few minutes of our webinar, and I want to try to synthesize a few of our final audience question answers into one, say, final closing set of remarks from you. The question is are about the biomarkers of vulnerable plaque, or just say predictors of potential downstream events that can be seen on non-invasive imaging. We'll say cardiac CT in this case. And if we should evaluate these in series, meaning when we identify so-called vulnerable plaque features or quantitative plaque abnormalities on CT imaging, first of all, are they reliable? Are you using them reliably, both either in your practice or based on the evidence that's available? And second, should we be serially following these abnormalities with serial imaging?
Well, if you want to stay on an evidence base, we do have some evidence that high risk features are associated with higher events. This starts with the very early study of Motoyama, which was really an eye-opener in 2009, 1,000 patients. And those who had positive remodeling and low density in their coronary arteries had a 20% event rate during follow-up, while those who had none or only one of these features had significantly and substantially lower event rates. So two plaque features which were adverse present in the coronary arteries, 20% event rate. So yes, plaque features are predictive, but it seems at the moment that plaque burden is more predictive than plaque features. For serial testing, no basis at the moment. If you want to stay evidence-based, there's no basis for serial testing. We never recommend serial testing.
Excellent. Stefan, thank you again so much for the contribution to the field, for spending the time this past hour on the webinar to inform our audience and really the totality of cardiac CT imaging communities out there. From me, thank you very much. If you want to have any final thoughts before we close, I leave the floor to you.
Well, I would like to thank you very much for inviting me. I feel that there's people out there who know much more than I do. And the more that I do work in coronary artery disease, it becomes just clearer that we cannot expect and shouldn't expect ourselves to be perfect. We can help the patients by narrowing down likelihoods, but we will never completely eliminate downstream events because it's simply so unpredictable. So we shouldn't be too harsh with ourselves if there's the occasional misjudgment that we do. We already narrow down possibilities and likelihoods for our patients that are already pretty good. But we always have to try as hard as we can so that we earn the trust that our patients place in us.
Well said, Stefan. And thank you again, not only from me, but from the SCCT, from the whole cardiac imaging community, to the webinar members that are listening in right now. Thank you so much for obviously tuning in, but contributing your excellent questions to the discussion. And to those that are going to listen to this in the future, thank you very much. Please make sure you get this educational content out there. Stefan is truly a titan in cardiac CT, and it's amazing to hear his perspective. Again, thank you, Stefan. And with that, I'll conclude our webinar.
Thank you.